All right. Good afternoon, everybody. We'll go ahead and get started. It's 12 o'clock, so welcome to Medical Grand Rounds at the University of Colorado. We have a truly packed room. I know I say this most weeks to try to get people who are home to come in, but we are absolutely packed, standing room only in the back. And I think it's because of who our speakers are today. So thanks, everybody, for coming. A little bit of a teaser for the upcoming weeks. Next week, we're going to welcome Dr. Ann O'Hare from the University of Washington, who will deliver the annual Collins Lecture. After that, we are going to hear our third and final installment in the Chief Medical Resident Lecture Series from Drs. Campbell, Saxon, and Scott. As a reminder, all lectures are open for CME and MOC credit. Questions will come from our audience primarily, but thank you to the chiefs who are not presenting, who will be monitoring the Q&A feature of the chat. And now I really am very pleased to welcome two of our chief medical residents, Dr. Meryl Colton and Yunan Ni. I'll say a few things about each of those, and then I'll turn things over. So Dr. Yunan Ni did her undergraduate work at Cornell, where she graduated magna cum laude. She was a medical student also at Weill Cornell, same name, slightly different location in New York, where she graduated AOA. She was obviously an intern and a resident here with us in the categorical track and the research pathway. And she will be going on to a hematology oncology fellowship at Yale next year. So we're going to lose her back to the East Coast. Her research, she worked in the Heasley lab while she was here at the University of Colorado. She participated in the development of an in vitro model of a high PD-1 ligand expression in murine lung tumor cell lines. She also assessed for differential response in ALK tyrosine kinase inhibitor therapy, and then did some work in the Cancer Center, a separate project looking at patient response rates, progression-free survival, overall survival, and duration of treatment in patients with ALK rearranged lung cancer in low versus high PD-1 expressing patients. Dr. Meryl Colton was an undergraduate at Duke. This will sound repetitive. She also graduated magna cum laude. She was a medical student here at Colorado, where she was also AOA. And has been a fabulous member of our residency, also in the categorical track. She will become a hematology oncology fellow at UCSF next year. She did some advanced training also at the Harvard T.H. Chan School of Public Health, where she got a master's degree in environmental health and environmental epidemiology. And her research here at Colorado involved creating a REDCap database to evaluate demographic and systemic barriers to hereditary cancer and screening at our urban underserved hospital, and also a separate project where she was the primary analyst evaluating flow cytometry of patients with T-cell lymphoma treated with chemotherapy checkpoint inhibitors, and then a combination of the two, looking specifically at the effects of one of the monoclonal antibodies on outcomes. Both Meryl and Yunan are truly exceptional people. And it feels weird to be reading off of this because I know them so well, but I don't want to get anything wrong. They are outstanding physicians, and each has been recognized throughout their careers in their training and their education. Yunan was awarded the Glasgow-Rubin Memorial Achievement Citation, as well as the Alfred Moritz Michaelis Prize in Medicine from the Cornell Medical School in her year of graduation. And her class as interns also voted her the Elena Kazarian Intern of the Year. Dr. Colton was a Robertson Scholar at Duke. She was an Adler Research Scholar here at CU, and she was the 2019 recipient of the Thomas Neff Award, which I will read to you, is given to the senior medical student who has demonstrated unique humanitarian concern toward the total health and well-being of patients with unrelenting patience and compassion. I think that's perfect. Both Dr. Nee and Dr. Colton have served as truly outstanding residents and chief medical residents here at Colorado. In a few weeks, they're going to go on to serve with equal power at UCSF and at Yale, continuing their journey to become excellent oncologists and leaders in the field of oncology. But before they can go, they have to give medical grand rounds. So I welcome Dr. Colton and Dr. Nee.
Wow, thank you, Jeff, for that extremely kind introduction. Like he said, I'm Meryl Colton.
And I'm Yunan Ni, and coincidentally, as you just heard, we're both going into HemOnc. And so we wanted to delve into a topic that comes up pretty frequently in this field. We're going to talk about personality as prognosis. Does being nice really increase your risk of cancer? Here's the QR code to scan for CME credit. Anyone needs that?
So our learning objectives for today, we're going to describe the definition of a nice patient. Then we're going to explore the association between personality traits and cancer incidence. And last, we're going to discuss maybe some alternative explanations for a common healthcare phrase.
So we're going to start with a case. And this was actually a patient that I took care of just a few months ago. So this is Mr. A. Mr. A is a 73-year-old man with past medical history of GERD, tobacco use disorder, and hypertension who presented to the ED for an expedited workup of a 40-pound weight loss over the last 6 months, dysphagia, and multiple liver masses seen incidentally on a CT obtained during a recent admission. So he did get an EGD, which showed a 4-centimeter mass, pathology report consistent with esophageal squamous cell cancer. So after the team received the call with the preliminary pathology report, a resident on the team remarked, "He's so nice. Of course it's cancer."
So who here in this room has uttered one of these phrases? Her cancer is metastatic. Of course, they're the nicest family. Of course it's cancer. He's so nice. She's so nice. Must be a poor prognostic sign.
So turns out we're not the only ones who are remarking on the risk of being nice and getting a terrible cancer diagnosis, as seen in these headlines from the general public and popular science.
So Yunnan and I set out to explore whether there was really any evidence to show that being nice will increase your risk of cancer.
But as with all good studies and good talks, we want to be specific and accurate about our definitions. So we'll start by defining who is the nice patient. We use the term nice all the time in our daily lives, and colloquially, it means someone who is pleasant in manner, agreeable, good-natured, polite, kind, pleasing, appropriate, fitting, socially acceptable. But who do we label as nice in medicine? Are they just the opposite of a difficult patient? But then who do we label as a difficult patient? So this idea of labeling a patient and knowing what sort of patient you're taking care of goes back centuries. This quote is over a century old. It is much more important to know what sort of a patient has a disease than what sort of a disease a patient has. Does anyone know who said this? Oh, I think I heard it. Some mutterings. If you said William Osler, who is what I think I heard, there you go, you would be correct. Our favorite father of modern medicine. So the idea of good patients and problem patients has been studied for decades, probably even longer. So let's take a look at the historical perspective. So this is a paper from 1975 that tried to characterize the good patient and the problem patient. So the good patient was someone with the characteristics of, quote, trust, cooperation, uncomplainingness, and undemandingness. So in this study, they asked patients whether they agreed or disagreed with certain statements. So whether or not they agreed with the best thing to do in the hospital is to keep quiet and do what you're told. Agree with doctors expect patients to obey them completely. Disagreed with I cooperate best as a patient when I know the reason for what I have to do. And patients that kind of agreed with those two top statements and disagreed with statements like the bottom were rated as more conforming. So interestingly, they found that the more serious the illness, the more likely the patient was to fall into that conforming category. And the highest percentage of patients who were very conforming were cancer patients. And these were also the patients that the staff that were participants in the study tended to rate as the good patients. But turns out they also can't be too conforming, or else they're also considered a problem patient, as demonstrated by this quote from one of the staff participants in this study. Give you a second to read that. And so that brings up the question of whether the nice or good patient and the difficult or problem patient are just sides of the same coin. So don't raise your hands, but think about whether you've ever used the phrase difficult patient or problem patient, either in your notes or when speaking to a colleague, maybe casually, or even just thought it to yourself. As it turns out, the term itself has been used as early as 1967, probably earlier, but that's what we have on the internet. If you just did the mental math there, that's exactly 56 years. And it remains in our lexicon today and is also still studied today. But we've come pretty far from the days of Osler and the idea that patients who obey doctors are good patients. We know that the factors that play into a patient being labeled difficult are complicated. It's not simply just the patient's behavior. It's not whether they're asking a lot of questions or being rude or disheveled. It's also the physician's training, biases, feelings of ineffectiveness in their practice. For example, the physicians most likely to report high frustrations are the ones who work more hours, had more symptoms themselves of depression and anxiety. It's also the pressures of the healthcare systems to see more patients in a shorter amount of time with unequal resources. So the complex interplay of all of these factors contribute to our labels, and that label can hide some of the biases underlying these labels. So who are the patients we label as difficult? These are patients that have mental health diagnoses. They're frequently labeled as difficult, and this has been verified time and time again. The presence of any mental health diagnosis, including anxiety, depression, dysthymia, was one of the factors most strongly associated with physicians rating a patient encounter as difficult. And the difficult patient was 2.3 times more likely to have a depressive or anxiety disorder. These are also the patients that have a history of substance use disorder. So physicians reported high frustration with these patients. Patients with alcohol use disorder were 2.6 times more likely to be rated as difficult. As stated by a patient, if you come here a couple times and you're known on the records as you're a drug addict or you're an alcoholic or whatever, then they label you and they don't give you the care that you normally should receive. And we know that women have historically been labeled hysterical. That's where the term hysterectomy comes from. And their pain is frequently undertreated. Symptoms are more likely to be played off as psychosomatic as compared to their male counterparts. And several studies saw a trend towards a greater proportion of difficult patients being female. Race and ethnicity have been well studied in this domain. So Black patients were 2.5 times more likely to have one or more negative descriptors in the EMR as compared to their white counterparts. And this study by Van Ryn and Burke demonstrated that physicians trended towards viewing white patients as more likely to be the kind of person they would see themselves being friends with. And physicians significantly viewed white patients as more pleasant, more rational, more likely to be educated and adherent. And these are all phrases and judgments that we know play into a physician's positive regard for their patient. Patients are also likely to be viewed less positively if they have a lower socioeconomic status. So again, from that study by Van Ryn et al., physicians tend to view these patients with a lower SES as less independent, less responsible, less intelligent, and less likely to participate, in this case in cardiac rehab. And finally, less continuity of care. So why is continuity of care important for labels? Well, when a provider doesn't see a patient consistently, that provider is less likely to learn about their motivations, their home life, their family, factors that aren't documented in a note or represented in a single lab value like a hemoglobin A1C. Our visits can be short, so they simply don't have the time. These providers are then more likely to potentially ascribe these patients non-adherence to lack of motivation or desire to take care of their health. And the important thing is this effect is additive with all of those other factors and characteristics that we just reviewed, because the patients that get less continuity of care are those that are non-English speaking, non-white, not insured, with a lower SES. So ultimately, it still remains hard to define or quantify who's nice because there's so much subjectivity and patient, physician, and healthcare system factors that all contribute. And maybe, it is the good patient. That's nice. Or the not difficult patient. What is clear, however, is that these labels matter and not only affect the physician-patient relationship in that particular encounter, but also follows that patient to other encounters. So as outlined in this paper by Park et al., we often write positive language statements like this pleasant 27-year-old or this nice 57-year-old without thinking. However, we also use a lot of negative language categories, statements like she is adamant that she cannot perform any kind of exercise, in quotes, to highlight poor reasoning, or he insists that the pain is behind his knee to question credibility, or she perseverated on the fact that a lot of stuff is going on at home, but that you wouldn't understand, as a way to depict the patient as belligerent. And your labels carry forward. So again, don't raise your hands, but think about whether or how many times you may have quoted a patient and why you did that in your note.
So while it's common to label patients in practice, it turns out it's really hard to objectively define nice as a research variable. And the closest researchers have been able to get to evaluate the relationship between specific personality traits and cancer incidence. So we're going to take the next few minutes to explore the association between personality traits and cancer incidence. Over the years, there have been many iterations of ways to characterize personality. However, the Big Five model, also known as the five-factor model, is the most widely accepted personality theory held by psychologists today. The theory states that personality can be boiled down into 5 core factors: neuroticism, extroversion, openness, agreeableness, and conscientiousness. This model of personality is assessed using a 44-item questionnaire to evaluate each of the components that make up the Big Five. Questions include things like, I see myself as someone who generates a lot of enthusiasm, or does a thorough job, or is original, or is reserved, or even is self-conscious. And ultimately, study subjects are placed on a 5-point scale between neurotic and stable, extroverted and introverted, open and closed, agreeable and hostile, and conscientious and spontaneous. So how could any of these personality traits actually increase your risk of cancer? Now, I'm trained as an epidemiologist, and as part of Hill's criteria, there has to be some biologic mechanism or plausibility to establish causality. So researchers hypothesize that some personality traits, like high neuroticism and high extroversion, have 2 pathways that increase the risk of cancer. The first is through stress. Highly neurotic or highly extroverted patients have fewer coping or release mechanisms, leading to higher rates of cortisol and increased risk of cancer. The second pathway is through this caregiver phenotype. They hypothesize that these patients will be more likely to avoid self-care, miss screenings, take on unhealthy habits like smoking, drinking, or lifestyles, in taking care of others, and in so increase their risk of cancer.
So, as it turns out, this is a question that has been asked in many studies. This is obviously not a comprehensive representation of all the studies out there. There are a lot, but it's a good sample of the largest. As you can see, with the green representing a significant association between a personality or personality trait and cancer risk, and the red representing no association whatsoever between the two, the results are actually pretty split down the middle. But let's take a look at a few of the ones with the largest sample sizes. So this first one is by Wait et al., and this was a study of 364,000 participants in the UK Biobank who were cancer-free at baseline at the start of the study. And these patients were all enrolled in the Biobank through health assessment centers throughout the UK, and when they enrolled, they were asked to complete a personality assessment based on that 5-factor model that Meryl mentioned, and also included a variety of social demographics and health-related information. So these patients were then followed for a median of 7.1 years until death, withdrawal from the study, or diagnosis of lung cancer. Interestingly, the study also identified polygenic risk scores, or PRSs, which represent the genetic risk for lung cancer in these participants through saliva, blood, and urine samples, as well as the genetic risk associated with neuroticism, which was kind of the personality trait they really looked at. So during the study period, there were 1,500 lung cancer cases incident. They adjusted actually for things like smoking, alcohol, BMI, exercise in one of the models, and then did an additional model where they adjusted for age, sex, background, education, family history, smoking, BMI, all those things that we think about as potential confounders or mediators. And in both models, the study actually did demonstrate a significant association between higher neuroticism and the risk of lung cancer. And as you can see here, the risk was actually higher with the higher degree of neuroticism. That top number is lower neuroticism, going down towards highest neuroticism, based again on that scale. And so they actually wondered, is there some sort of genetic link? Well, what they did find is there was a joint effect of neuroticism and that genetic risk for lung cancer. And the patients with the highest genetic risk and the highest neuroticism, as you might imagine, have the most risk for lung cancer. And this kind of suggests that maybe there's some additive interaction between this high genetic risk that we already kind of can quantify and high neuroticism. So the second study was a prospective cohort study of 11,000 Japanese residents who were again followed until death or diagnosis of really any cancer, with a median study follow-up of about 7 years. So this study also looked at the association between these personality traits, again, kind of focusing on neuroticism, but they also looked at behaviors that we know are associated with cancer risk, such as smoking, alcohol consumption, fruit and vegetable consumption, and physical activity, BMI. And so they really broke that down. So men and women with a higher level of neuroticism tended to eat less fruit and vegetables, tended to have less exercise, higher risk BMI values. And men and women with higher extroversion tended to have higher smoking rates. However, even after adjusting for all of these behaviors that are associated with personality, higher neuroticism was still associated with a higher risk of cancer. Interestingly, though, women with a higher neuroticism score had lower cancer mortality after they were diagnosed. So those are our two positive studies. This third study by Jokela et al. Took pooled data from 6 prospective cohort studies, which had a sample size of 42,000 men and women across multiple countries, mainly the UK and the US, that were followed up for, again, average of 5.4 years. They looked at both the association between personality traits and lung, breast, colorectal, prostate, skin, leukemia, lymphoma cancer, as well as the cancer mortality. And in this case, long story short, there was no association among any of the personality traits for really any of the cancers. And finally, we have the Nikaya study, which was a study of 59,000 Swedish and Finnish participants from a cohort study. And they evaluated specifically the association between extroversion and neuroticism with development of cancer. And they actually followed them out to a maximum of 30 years. Again, they collected a lot of demographic and healthcare characteristic data. And so when they looked at any cancer as a group, they didn't find any association with neuroticism or extroversion. However, they did find when they broke those cancers down that higher neuroticism was actually associated with a lower risk of liver cancer, though caveat being that there was just a really low incidence of liver cancer in general. But potentially more interestingly, in both unadjusted and adjusted analysis for all those health characteristics, there was a significant association between higher extroversion and higher neuroticism and lung cancer. Again. So they did comment that they weren't able to collect very precisely for smoking status at times. And so they posited, if they had perfect data for smoking status, that association would disappear. So overall, about half and half. So maybe the jury is still out despite all of these studies. But a lot of these results suggest that there's something else about personality. What is it about personality that is contributing to this cancer risk? So could it be that some personality traits are associated with behavior? We kind of already know that. But specifically, do personality traits decrease your likelihood or increase your likelihood of getting cancer screening? Could be, actually. So several studies have asked this question. And actually, the three biggest ones that I found did find an association. So for example, in that first study, which was the largest, they looked at 14,000 men and women and found that things like higher conscientiousness and extroversion were linked to higher rates of breast, cervical, prostate, and colorectal screening. Higher neuroticism linked to higher rates of colorectal screening specifically. That second study with about 2,000 patients found that, again, higher neuroticism and extroversion was actually associated also with increased breast cancer screening. And lastly, the smallest of the three studies found that higher neuroticism was associated with lower prostate cancer screening in men.
Ooh, that was a lot of data. But ultimately, what we're trying to get across is that the results are pretty mixed. Some studies showing positive associations, some showing negative associations, but we can sort of see that pathway through behaviors that it might be happen. What we really want to hit home, though, is that there are risk factors that we know increase your risk of cancer, right? Things like dietary habits, specific infections, tobacco use, genetics, and environmental exposures. Surrounding all of these factors are the forces that disproportionately affect certain groups and have led to profound disparities in cancer incidence and survival that we see today. And while the evidence is still pretty mixed on whether personality traits can lead to higher rates of cancer, the 987 studies used to put together the 2022 American Association of Cancer Research Cancer Disparities Progress Report are not ambiguous, highlighting this especially important call to action within oncology. So if there is an extremely large body of evidence about what actually causes cancer, why do we continue to propagate this phrasing? So we talked about defining the nice patient and explored the association between personality traits and cancer incidence. We're going to spend the last part of this talk discussing an alternative explanation for this common healthcare phrase. The first idea is that instead of being nice leading to cancer, maybe there's something to the diagnosis of cancer that causes people to become nice. We all have an Uncle Gary who was a total grump his whole life. But after he passed away, we put him on a pedestal. Maybe we see people differently once they have cancer. However, there's actually some evidence that a cancer diagnosis can truly make you nicer. There's something called trauma processing theory, where some patients actually experience post-traumatic gratitude instead of post-traumatic stress. A review by Mosher et al. Highlights how patients may have positive personality changes after a cancer diagnosis through closer relationships to others, greater appreciation for life, clarifying life priorities, increased faith, increased empathy for others, and better health habits. Although we all know this doesn't happen to all of our patients, right? We're all familiar with the grief cycle, and we've all counseled and supported patients who experience anger, depression, and bargaining in their own grief cycle. So what if the use of this phrasing isn't about our patients at all? One idea revolves around something called the just world hypothesis. Most healthcare providers see the world as a just world. And in this world, good people who do noble acts are rewarded. In return, people who are bad or evil are punished for their deeds. We call this the just world fallacy, or the tendency to believe that the world is just and people get what they deserve. This way of thinking is used to understand some of our most challenging questions we encounter in the world. Why are some people abused while others are not? Why do some people experience poverty while others do not? The just world fallacy tries to make sense of these events in the absence of a clear explanation. However, it's also a simplistic and inaccurate way of understanding that ultimately results in blaming others for their circumstances. But many healthcare workers find this idea comforting and are motivated to get up and work long hours by the idea that they're helping or rewarding deserving people. But when we see a case that has no reason, right? This person did everything right. They're so nice. They shouldn't have cancer. It violates the just world fallacy. And Yunan and I wonder if we just remember these cases more than others. So maybe the nice people don't get cancer more often. We just remember the devastating experience of taking care of them. And this isn't surprising, right? As Yunan and I reflect on our recent time reading residency applications, we were struck by the stories of loved ones' personal experiences with the healthcare system. In some ways, we all see ourselves in our family and our patients. Maybe the nice patients just remind us of ourselves. And it's also more than that. This is Dr. Julia Limes. I'm so sorry. A talented hospitalist and a senior associate program director. She was actually on service last week as she helped Yunan and me prepare for this talk. Partway through our presentation, she stopped to check a patient in Epic. She described a 35-year-old patient with metastatic cholangiocarcinoma who was admitted with pneumonia and now approaching intubation. Offhandedly, without remembering the very topic we were discussing, she proclaimed, "And of course, he's just the nicest guy." At this, we all paused. Why did she say that? Was it really about him being so nice? Dr. Limes had a really busy week on service with several really sick patients. And in sharing this phrase, she seemed to find comfort. Why is there solace in declaring certainty, of course, as if to bring reason or comprehension to a case so deeply incomprehensible? Somehow irony being more comforting than tragic coincidence. Or is it just code, shared language, a socially acceptable way to display your grief? One well-known implication of grief among healthcare professionals is the development of compassion fatigue. Compassion fatigue is made up of secondary traumatic stress, or STS, and burnout. And this term refers to a traumatizing emotional state experienced by healthcare providers who are preoccupied with the suffering and distress of those they care for. And it is expressed in a reduced capacity or interest to be empathetic towards others. This study by Braun et al. Set out to study how our sense of control might be related to compassion fatigue, specifically secondary traumatic stress. And they assessed our sense of control by comparing physicians who had an internal locus of control, meaning they believed that they or God had control over a situation, versus people who had an external locus of control, meaning they believed things just happened by chance. And they found that those that believed things happened just by chance actually had higher feelings of helplessness and in turn higher rates of secondary traumatic stress. Alternatively, those with an internal locus of control had less helplessness and lower secondary traumatic stress. So maybe there is evidence that finding some reason why a patient has cancer, even if it's completely unjust, is more comforting than horrible coincidence. Well, let's go back to this idea about specific phrasing, how the specific phrasing we use can act as universal code to discuss our hardest cases. There's a principle called social acknowledgement, which is defined by one's peers validating an internal grief process. In post-traumatic stress literature, they talk about how some forms of grief are more socially acceptable than others. Like, it might feel easier to seek validation for the sadness of losing a parent to cancer than, say, being sexually assaulted while intoxicated. But many have found that social acknowledgement can be a powerful tool to ward off PTSD in the face of trauma. So this study by a group of authors in Israel posited that social acknowledgement might actually mediate compassion fatigue. They took 80 psycho-oncologists and used K-means analysis to group them into 3 clusters. Cluster 1 being high grief and low social acknowledgement. Cluster 2 being medium grief and high social acknowledgement. And cluster 3 being low grief and medium social acknowledgement. And they found that the group with medium grief but high social acknowledgement had the lowest rates of secondary traumatic stress and burnout compared to the group with low social acknowledgement. So there seems to be something about these phrases that helps us relieve our own grief. But everything we've talked about today illustrates that we comment on a patient's personality or niceness in the face of a horrible diagnosis for many reasons. And it might just be all about our relationships. But as Yunnan and I went through the literature and read countless papers until our brains were mush, we couldn't help but ask, does any of this really matter? And therein lies the last question. If we truly see some patients as nice, do nice patients receive better care? There's some researchers who tried to study this. And while again, they didn't look at patients' niceness, they looked at markers of patient and provider communication and concordance and found that poor communication could lead to worse pain control, worse understanding and adherence to medications, and worse understanding of your prognosis. However, even a good relationship could result in over-testing our imaging. And there's many things that we might do that we think are being helpful to a patient that's nice that actually cause them more harm.
So ultimately, in medicine, we label our patients constantly, nice or not nice, difficult or not difficult, whether that's conscious or unconscious. And while we'd like to think that we're objective in giving these labels and that they're just about the patient, it's, as we kind of talked about, likely that a lot of these labels are actually shorthand for the relationship between ourselves and the patient. So our whole job is about relationships. You can't really completely remove them. And in fact, it's probably what drove many of us to practice medicine in the first place, and what helps us cope with grief. So maybe these labels have their place in our practice, and they may or may not increase your patient's risk of cancer, but regardless, they are powerful and carry forward. So today, we hope to just describe the definition of a nice patient, explore the association between personality traits and cancer incidence, and to discuss alternative explanations for this common healthcare phrase. And what we concluded was, in medicine, we label constantly, and those labels aren't benign. And that maybe some personality traits are related to cancer or cancer risk, but not as much as other risk factors.
And ultimately, the statements that we use to talk to each other really just reflect our relationships with our peers and our patients, and they help us process our grief. So we just want to thank so many people who gave us this opportunity to talk to you all today, specifically the whole CU Internal Medicine residency program, our co-chiefs, our oncology mentors, our family and friends. It's been a great opportunity, and we'll take questions.
That was excellent. Thank you. I will throw it open to questions from the audience first. And I'll take a little prerogative while we're waiting for folks to generate their questions. When you're reading, when you were thinking about, I was interested in the idea that how trauma changes people. Do we know, is there any way to predict how trauma is going to change? Like who turns into that more solace-seeking, empathic person, maybe more faith-based person, and who goes down that slightly more challenging pathway that might show up as the patient that gets labeled as difficult?
So, actually, yes. There have actually been a lot of studies specific to cancer patients and how they respond to a cancer diagnosis. And it is actually related to a lot of those personality traits that we talked about, that 5-factor model. But it's also more than that. There is a lot of association with the relationships that these patients had with their caregivers, and how those caregivers react to that diagnosis as well. So maybe not predicting 100% who's going to react in what way, but you can probably make an association on the back end.
Dr. Sudar?
Thanks, guys. That was an amazing talk. Curious, when you did your literature review, did you see any association between certain personality types and kind of overuse of the healthcare system? It sounds like there was an association between personality traits and kind of cancer screening, but also could think about, is there an association with just kind of, I shouldn't say overuse, but use or access of the healthcare system?
Yeah, Yeah, there was. Not all of them were in the studies that I cited. Some of them were outside of that and specifically looked at utilization of the healthcare system. It tended to be patients with a higher conscientiousness score, higher neuroticism score. But again, I think one of the things that we really noticed was even though you may find certain personality traits, it doesn't encompass the whole personality because those traits are on a spectrum and together they form that personality.
I think the backhand of that and what sort of comes out in the studies is that I think the hard part is that one personality trait doesn't drive the entire story, that the context is a big part of it. So there might be one patient who's has like a high level of neuroticism, who is calling the doctor all the time and using the healthcare system all the time. There's that same patient with a different support system in a different country, in a different healthcare system, who is afraid, is like so overwhelmed by their anxiety or their neuroticism that they are then avoiding the healthcare system. So I think that's why it's another reason why it's not just this like strong one-way rotation, is that these personality traits live in the context of all your other personality traits and in the environment that you live in.
There's some online questions, so I'll throw it over to the chiefs, the other chiefs.
Thank you both. This is actually a question from your co-chiefs. Curious what you guys think. I'm sitting here wondering, what language should I use in the chart as we communicate with each other through our documentation? Should we use positive language to talk about our patient? Should we stay perfectly neutral? Should we not use quotations? My notes are fraught with that, sometimes for humor, but would love to hear what your takeaway is from all your reading.
So I think what I took away is, I would say a lot of those positive and negative language, we do it unconsciously or we just don't think about it. I personally will be trying to not use as much of that, but I do think sometimes there's a place for it. Like if you're trying to convey, for example, someone's struggles with access to transportation, you may say they mentioned that it takes this amount of time to get to the hospital or this amount of time to get my medications. But I think I would just be thoughtful about what I'm actually trying to say to my reader, which is going to be the next provider or the nurse or someone else.
Yeah, I think our big takeaway from this was not to shame people in the way that we use labels, because it's just the true nature of like our job and that we work with people all day. And there's no way I think we'll get to a world where we don't use language inappropriately. I think it's to be conscious that they're powerful and that they can have consequences, and where possible, trying to be as objective as you can with what you're trying to say.
Dr. Davis.
Fantastic job, you guys. And I think as an oncologist, it kind of hit home to me that we're the greatest example of where we kind of use these terminologies because of those really intense, sometimes short, sometimes long relationships with our patients, where we're seeing them go through terrible things and really getting to know them. So I think I love that highlight of our field for that. But also I think for the rest of the group here, it's important that we probably do this in other areas too outside of oncology. So something to keep in mind in all of your patient encounters. The other thing I had a question on is, I think something I see in myself too is, as we're going through the treatment course, right? Like identifying these people who, because of their niceness, are they at risk of getting cancers? But also I think in the treatment course, I think that point is an interesting one too. Was there other literature that you guys saw for certain cancers or specific to a certain tumor type where you saw that kind of correlated with their outcomes on cancer treatment? Or is that an area of research you guys came across?
Yeah, I definitely didn't see any like specifically.
Yeah, I mean, there were some not great quality studies and rather older ones that, would find things like higher neuroticism or higher extroversion was associated with thickness of tumor and melanoma, which, I don't know if that's truly a true association or if there's something else going on. But I do think we did notice that, for patients with certain characteristics, they might be more likely to follow up in clinic. They might follow up that initial diagnosis sooner. They may get, the cancer resected earlier. But on the flip side, we also definitely saw like kind of the way that physician biases may also play into that. Like there's a study that showed that, for example, like patients who are Black tended to not get their lung cancer resected when it was an early stage. That was a stronger association. And then developed worse mortality because their cancer then progressed to stage 4 and were uncurable.
And then these studies that are looking at does sort of our labels, our relationship affect our treatment plans? These are in a pretty diverse range of cancers. So the worst pain control and the worst understanding of your prognosis were done in general oncology clinics where they had a really diverse range of oncology patients, melanoma, lung cancer, liver cancer. But there's definitely, I think, an area I'd like to explore a little bit more, because I think it's one of the themes we were sort of circling around the whole talk, was that even within cancer, there's different types of cancers. There's the breast cancer patient who has a BRCA mutation, gets a very different persona about them just immediately than the liver cancer patient, right? Or even the lung cancer patient who smoked and has lung cancer. And I think that this is something I just didn't explore enough, but might be out there. Yeah.
Dr. Campbell?
Sunad has an online question for you guys. Is there any difference in the goals of care discussions of patients who are nice versus difficult? And if so, how many of them would end up dying in the ICU versus more comfortably at home versus hospice?
Yeah. And so I think that gets actually into this paper around poor patient provider communication and worse understanding of your prognosis. This was very much, there's a lot of literature around this. And again, it's hard, right? If it's about niceness, it's so hard to study that, but there's been a lot of, in this paper, they looked at do I agree with my physician? Do I understand my physician? Do I like my physician? Do I feel like I have a good relationship with them? And the folks who didn't have that didn't understand their prognosis and didn't understand what was going on. And so I think you could easily take that, project that and say that they would maybe do better at home or don't get the end of life care that they should get.
And it also goes the other way. It's not just how the patient views the physician, but how the physician views their patient. So when we talked about who the physician sees as agreeable, that they those also are those positive regard characteristics are associated with better provider patient communication. So I don't know that we have an exact answer if they're nice, we do this. But I think it's definitely interesting.
Kick it over to Amran. She has your question. All right, great. All right, if there are no other questions, I'll take one last chance. I would like to ask you maybe just to take all of this and provide both of your sort of summaries. And it gets at Brady's idea of question, but even beyond what we put in the chart, I think a number of years ago, we used to tolerate some of this talk about difficult patients, and we justified it as, well, we have to blow off steam. It's gallows humor. It's part of our well-being. And we don't do that anymore. Do you think we're going to move into a place where we don't tolerate the labeling as nice because it's problematic in certain ways? Or do you think that might be a bridge too far?
I don't know. It's hard, right? Because we need these relationships to do this job. We need to find satisfaction in our work. I think it's such a big part of our own support and healing. I think I feel better about it, knowing it's you're highlighting a positive thing about the patient, but you're right, it's not completely benign in and of itself. I wonder if there's another way to sort of get at and honor, this was a really hard case for me, or this hits a certain heartstring for me, and I'm having a hard time. If we can get better at just saying that. But I don't think I would come down on it right now.
Yeah, I'm on the same page. I actually, and Dr. Gardner over there knows, I sent a sign out email last night for my team because she's covering me today while I'm doing this talk, and completely didn't even realize I did this until after I sent the email. I wrote, "This is a super sweet, super nice patient, and the patient had cancer, incidentally." And so I looked back and I was like, I think I was trying to say, like, even though he has a lot of medical complexities, he can sometimes be really anxious, express a lot of worry, and I think can sometimes be frustrating to like answer all those questions. Like, he really, really is like a great person, and we should view him in that light. And so I feel like for me, I was like, what am I trying to do with this? So I think that's where I think maybe the future is. Maybe we debrief more or are more careful about debriefing, taking away some of that kind of like need for that term as a way to express grief, but maybe also use that term thoughtfully as a way to say like, hey, don't just discount this patient because of their current situation. Like, this is who they are. Though maybe not use the word nice, maybe be a little more descriptive.
I think that's a perfect place to end. Dr. Nee, Dr. Colton, thank you. It was brilliant.